I'd like to introduce Dr. Burt Berkson from the United States, who treats patients with cancer and autoimmune conditions using low-dose naltrexone. Dr. Berkson, could you tell us how you heard of LDN?
You want to know how I first met low-dose naltrexone? Well, one day a gentleman came into my office about 15 years ago, and he came in with a walker, and he was in terrible pain. He had just been told by a large university cancer hospital that he had only about a month to live. He had terminal prostate cancer with metastases to his bone. He was in horrible pain. But he also had rheumatoid arthritis and lupus, mixed collagen disease. And I asked him what I could do for him. And he said that he was told he was going to die within the month, and he was in terrible pain, but his wife had senile dementia, and he had to have her placed in a nursing home before he died. And I asked him what I could do for him, and he said, would I give him narcotics to help him with the pain so he could accomplish this task? And I said, sure I would. Then he asked me if I ever heard of Dr. Bahari in New York. And I said, no, I haven't. And he said that he heard he was curing cancer and rheumatoid arthritis and other autoimmune diseases. And I said, well, why don't you go up and see him? He said, well, he's just in a very small office. If he was any good, wouldn't he be at one of the big cancer centers? And I had previously told him my story about when I was working with alpha-lipoic acid at a big university medical center in the United States. And when I published a paper on 79 people waiting for liver transplants and gave them nothing but lipoic acid, 75 regenerated their livers within a month. And I was all excited. This was published out of our National Institutes of Health. But the University Medical Center wasn't interested in this. They were interested in transplanting livers, not regenerating livers. And I said, they were very angry with me. And I said, probably if this man had some idea about curing cancer, and he was at a big medical center, he might put them out of business. And he decided to go up and see Dr. Bahari. Well, I didn't see him for 3 years. 3 years later, he walked in the office. I thought he died without his walker, just completely normal. And I asked, John, how are you doing? And he told me that he had a sinus infection. I asked, what about the cancer? Oh, Dr. Bahari cured that in the autoimmune disease too. The rheumatoid arthritis and the lupus is under control. Well, I saw him with my own eyes, but I was still very skeptical. And I had a number of patients with various autoimmune diseases, rheumatoid arthritis, systemic lupus erythematosus, MS, dermatomyositis, Crohn's disease. And when they would come into the office, they were usually being seen by a rheumatologist. I would ask them, do you want to try this and see how it works? And many of them said, no, I'm happy with my expensive drugs with the rheumatologist. And I said, fine. But others said, yeah, let's try this. And the people who tried the low-dose naltrexone, almost all of them, within a month were off all of their expensive, potentially harmful drugs and were feeling normal. So then a gentleman came in about 8-9 years ago with pancreatic cancer and metastases to the liver. He was a stage 4 pancreatic cancer patient. And he was also a patient at a big United States Cancer Center. And they told him there was no hope. They did chemotherapy, it just made him sicker. and the cancers continued to grow. He was told that he would die within a very short time. He should go to hospice and die there. And he came in with his young wife, and he had a young son. He was only in his 40s. And I asked him if he wanted to try this treatment. And he said, of course. Well, within 1 month, he went back to work as an engineer. And he actually tells the story in Honest Medicine. It was amazing. I was amazed by it. Now it's 8 years later, almost 9 years later, there's still the cancers haven't grown. At one time, they seem to have been gone on PET scans, but then he stopped treatment and they returned, and we put him back on treatment. And the cancers seem to go dormant again. And then I published this information in one of the big cancer journals in the United States. Absolutely no interest whatsoever by American oncology. Nothing. Even when people write this information down and send it to Wikipedia, it seems to disappear after a day or two, which I don't understand. Then a number of other people came in, and I gave them the choice. They were terminal. I said, you want to try this? And many of them said yes. And some did extremely well, and others didn't. But I published another paper not long ago. It was in December of 2009 in one of the big cancer journals, on 3 more people who had terminal pancreatic cancer. And within 6 months, there was no sign of cancer on the PET scans. And absolutely no interest by the oncology community. Nothing. I'm amazed by this. But I was originally a professor of microbiology at one of the big universities on the east coast of the United States, at Rutgers University. And I decided to do the medical training a little later. I had the first 2 years of medical school, and I had about 6 years plus of education above medical school, but I didn't have the hospital training. I had the education, but not the training. And once I started doing the medical training, I saw that in medicine, most doctors, they will only accept information from their specialty group. If it's from somebody else who's not an oncologist and is not a hepatologist, they really shut off their ears. They don't want to hear.
What other cancers have you treated with low-dose naltrexone?
Well, we've had several great successes and several failures. We had one woman who came in with hepatitis C that I had been treating for a long time, and I've published papers on that too. And she did very well. She was a nurse, but she stopped all treatment after she felt good, and developed cancer of the liver, hepatocellular carcinoma. And she came back in again and asked if I could do anything for her. And I said, I don't know, let's try. And we put her on low-dose naltrexone and intravenous alpha-lipoic acid twice a week. Well, maybe six months later, we did another PET scan. There was no sign of cancer. So that was a remarkable change. Mm. Then a man came in with a B-cell lymphoma, and he had been all over the country at different medical centers, and he did not want to do the standard chemotherapy. He refused it. And he had these lymph nodes in his neck and his groin. They were as big as softballs. They were like 16 inches in circumference. And we put him on 2 weeks of intravenous lipoic acid and low-dose naltrexone at bedtime. He stopped the lipoic acid after a short time. He stopped living his healthy lifestyle that we recommended, went back to his old ways, but his wife forced him to to take the low dose naltrexone at bedtime. He came back about 6 months later, and there was no sign of lymphoma anymore. He was completely clear. You know, we've had several cases like that. Then we've had other cases where the cancer did not clear up, but it seemed to go dormant for long, long periods of time, various types of cancer. Mm-hmm. Then one day I received a call from the National Cancer Institute in Washington, our government's cancer institute. I didn't think anybody read the papers. And the chief wanted to know if I could come to Washington and explain to them what I'd been doing. So I was sort of surprised by this. And I flew to Washington and spoke about my successes with autoimmune disease and cancer. The group of scientists and doctors, I thought they'd argue with me, but these people were mostly scientific-minded doctors. They actually stood up and applauded. And afterwards, the chief of oncology at one of our Ivy League schools had flown down from north of Washington to hear the speech. And he said he had an aunt who had breast cancer. But I give him a few minutes and suggest how I treat people, and I did. They said, well, how do you treat your cancer patients? I said, well, I give them chemotherapy and radiation. But he was interested in low-dose naltrexone for his family member, which I found interesting.
And what dose do you start people on?
Most people I start at 3 milligrams. And then, if they do well on that, I'll go up to 4.5. Many stay on 3 milligrams and do very well. We haven't had any serious side effects such as insomnia or bad dreams, but I always give them a little bit of alprazolam or lorazepam to take the first few nights when they're on low-dose naltrexone so they can get a good night's sleep.
Mm-hmm. What are the gems can you share with us?
You know, I wrote a couple of chapters in Honest Medicine. Mm-hmm. And I think one of the chapters it was on hypnotic trances in humans. And I sort of described how I was when I was growing up. I had a relative who was a medical doctor from a very prestigious medical school in the United States. And whenever the family would talk about him, they would say, well, he's much better than a medical doctor that went to a less prestigious university. And I thought, you know, why was that? I mean, why would one university be better than another? Mm-hmm. And they'd say, well, you know, everyone knows this is a better university. And I always asked questions. I was sort of a curmudgeon or something. But I'd ask questions, and I believed if he went to this better university, he must be better than a doctor who went to another university. Well, I got married, and I was a professor at the time, and my wife had repeated miscarriages. The babies would be miscarried in between the 4th and the 6th month. They were completely healthy babies. And we would ask to heads of very prestigious medical schools, heads of gynecology, thinking they would really know more than somebody from somewhere else. Mm-hmm. And this is 40 years ago. And they would keep telling me the same thing: get her pregnant again, and maybe this time she'll carry the baby. And this just seemed silly to me because she had 5 miscarriages, and it was very tough on her and me. Mm-hmm. So one day I went down to the university library where I was working as a professor, and looked through the journals on gynecology, and I saw that there was a doctor in India, in a small town in India, well, it was a large area of India, who found that if people had repeated miscarriages, it was usually due to the doctor, the gynecologist, or the obstetrician, doing a D&C on the patient after the first miscarriage and lacerating the cervix of the uterus. And he found that if you put a little stitch in there, or as he called it, a ligature, a band around the cervix to provide support, the woman would get pregnant again and have normal babies. And the babies could be delivered by a C-section, cesarean section, or they could remove the band and she'd have the baby normally. Mm-hmm. So I took this information to our prestigious obstetrician from one of the fanciest schools in the United States and showed it to him, and he tore it up and threw it in the garbage. And he said, "You're a microbiologist. Do I try to teach you about germs? Don't try to teach me about gynecology or obstetrics. You realize I'm a professor at so-and-so university." And I thought, my God, I was in a hypnotic trance about this. Here's a doctor in a small area of India who knows a lot more about gynecology than this fellow who's the head of a department at a big university. So what we did was we found a doctor in New York who had studied with Dr. Shiratkar in India, and his name was Martin Kleiman. And we went to see him, and he examined my wife and said, get her pregnant again, and we'll see what's going on. And we did. And we visited him, and he put in this little ligature, and she had a normal baby, thank God. And right after she had another normal child. And my daughter's a lawyer now, and my son's a medical doctor in practice with me. Mm-hmm. And this sort of broke this idea that somebody who has a lot of prestigious titles knows more than just a medical doctor practicing in a small town or with a less famous university. And I see this as very true. And then I remember when my research mentor and research partner, Dr. Fred Barter, who was the chief of endocrinology, hypertension, and liver and kidney disease at our National Institutes of Health, when we published that paper on the 79 people who were waiting for liver transplants, and 75 regrew their livers, regenerated their livers with just lipoic acid, we published this material, and we went to several prestigious universities around the United States speaking on this information. And Dr. Barter would speak first, and he would talk about these remarkable results we were getting with regenerating organs. And he'd finish, and before I'd get up to speak, somebody'd always ask the question, and they'd say, "Dr. Barter, you're the world expert on kidney disease, diabetes. You're probably the most well-respected internal medicine doctor in the world. You're chief of National Institutes of Health. You're a kidney expert. What right do you have to treat liver disease?" I was shocked by this. Mm-hmm. And rather than saying, "Give me a break," we're giving you some very important information, accept it. But the person, he would say, Dr. Berkson serendipitously discovered that we could regenerate livers with this. Isn't this important? They say, "Dr. Berkson, he's more of a scientist than he is a medical doctor. He should stay in the laboratory and fiddle with his test tubes." and stay out of liver disease. So this is sort of this hypnotic trance people are under. And I'm sure we've all encountered this in our lives.
What would you say the future of LDN is? Where do you see it going?
Well, when I was speaking at the National Cancer Institute, one of the people who worked there, one of the scientists came up to me and says, "You know, Berkson, this is amazing information. I was really impressed by it. But you realize it'll never catch on unless we have a Great Depression." He said that it's cheap. No one can make a lot of money on it. It's very effective for many different diseases. Drugs companies are interested in a drug for one indication, not something that works for so many things. He said it'll never catch on unless the economies go down the toilet. And my answer was, I hope we never have a Great Depression. So I hope it never catches on in a big way, if that's what it takes. But I think people should have the information and make their choice. There should be medical freedom. If a person wants to do chemotherapy and radiation and extensive surgery, that's fine if that's what they want. But if they want to try something like low-dose naltrexone and intravenous lipoic acid, that's fine with me too.
Well, let's hope that it more than catches on.
Yeah, I think so. You know, I have several patients that come in from all over the world. We have people from Indonesia, from all over Europe, from South America, all over the United States and Canada. And many of them are very wealthy. And I've mentioned to them, maybe we could start a group to start supporting research on this. You know, it really saved your life. But, you know, when it comes to putting out large amounts of money for research, most wealthy people want to know what their return on their investment would be. I don't know what the future is. I think as more and more people get together, and maybe we could form some type of a group where all of the people that are getting well can support research. I would love to do a large study at one of the local universities, but there's no money for it.
How much would you say that would take?
I have no idea, but it would run into millions of dollars, I know that. Well, you know, in the United States at least, in order to get a drug through the Food and Drug Administration, it costs hundreds of millions of dollars. And if a pharmaceutical company wants a drug approved, they may spend $1 billion to jump through all of the hoops for the FDA. So they want to protect their investment. They've invested this large amount of money. They should expect a return on their investment. I mean, I believe in capitalism, but I think that drugs such as low-dose naltrexone have a place too, and I think people should know about it, and these people should be able to use it, and compounding pharmacies should be able to make it up. I know in the United States, the FDA has been giving compounding pharmacies a hard time, and they just don't get the kind of support that they need, you know, for the general population. Because most people here, at least, that if it's a drug from a big company and it's very expensive, it has to be better than a drug that costs a few dollars and is off patent. And if the drug company is well known, they know what they're doing much more than a compounding pharmacy, they believe. And if a drug company gets a professor at a Ivy League university to put his name on one of their publications, they think that's more important than an article that comes out of a smaller university somewhere else.
Mm.
They're in this hypnotic trance, and I don't know how to break it.
Thank you, Dr. Berkson, for speaking with me today. I really do appreciate it, and for sharing your experience of LDN. We wish you every success in the future.
Well, I hope so too. It's a pleasure, Linda. Thank you.